Welcome to everybody. And I want, on behalf of the Community Affairs Committee of Quechee Lakes Landowners Association, of which I am a member, I'm Ann Vernon. I want to thank all of our committee members for the work that they've done to put together this series of programs to help all of us as we age, or help our children as we age, to know what we need to do to really be planning for our aging and not ending up in crisis situations that are just not needed for us or our families. So we're really happy to offer these programs to the Quechee Lakes community, but also to the broader Upper Valley community. And that's what our Community Affairs Committee is about, is to try to really share what we have with everybody. Our committee member, the core committee members are Dick Davis, who's over here, and who actually kind of got this idea. Pat Peabody and Linda Labriola, who were welcoming everybody as they came in. Those guys are organized. I do have one announcement, which is everybody has their handout, so there's an agenda in the handout that we'll just briefly go through. So the one announcement is that Nancy Pescia, who was our speaker, first speaker, is unfortunately had an emergency. She's not going to be able to be here. So she is a private case manager. She's certified by the National Association of Case Managers, care managers, and does, so she was going to talk about what she does, and I will briefly do a little quickie thing about that once we get started, just to start as the introduction. But first we'll do the sort of the homework piece of this. So the other piece is just to follow the agenda. We just want to be sure that you know that the CATV is recording this program. If you are not comfortable, a good portion of our program is questions and answers. So we want to be sure that we have plenty of time for that. If you're not comfortable asking a question directly, knowing that we're recording, then please use the cards that are in your folder to note a question. And when we get to the period, Pat and Linda and Dick will be collecting those, and we will work with that way. Otherwise, we're encouraging people to ask questions, and we want to have a good dialogue. So let me see, the agenda itself, which of course I hate paper and all those numbers and everything. Anyway, I wanted to point out what's in your folders. The cards. Save the Dates has the dates for each of the next sessions that we're going to be doing through the summer. The In Case of Emergency card is something we've been handing out to everybody. It's something, we're calling it the refrigerator card, so it's something that you can put on your refrigerator with emergency information just in case something happens and the EMTs end up at your house. Dartmouth Hitchcock, the Aging Resource Center, who is going to be at our next program in July. The July program will be the Dartmouth Aging Resource Center Program Manager, Melina Walker, and the executive directors for Thompson and Bugby Senior Centers, talking about what they do, what services they provide, and really significant resources that are available to all of us. Where was I? Why did I mention that? The cards, yeah. So the Aging Resource Center also has a similar thing that's in like a pill box that you put in your refrigerator. So whatever works best, and the EMTs are trained to go over and look at your refrigerator to know where to find that information. There's an evaluation form that we ask that everybody complete at the end of the program and just hand in as you go out. And then considerations for our family notebook is another thing that Dick Davis actually developed. And it's really just a checklist for what kinds of things you really need to put into a notebook that tells your family what they need to know when needed. On the other side is basically the handouts for today. You've got your agenda. There's an article from the National Institute on Aging. There's no place like home. Just some tips about if you are thinking that you really want to stay in your current home, and that's what this program is about. These are some thoughts and some ideas. Another group that we have found to be helpful is the National Aging in Place Association, or Council. So we put into your handout the first 3 pages of their planning guide, which is online. You can actually do it online if you want, or we will have some handouts, printed planning guides at the table as you're leaving. And then a couple of articles from our panelists. So to get to our panelists, Nancy's not here. This is Sheila Aubin, who's the Vice President of Clinical Operations for the Visiting Nurse and Hospice of Vermont, New Hampshire, formerly the BNA. And actually, interestingly enough, my career has been in healthcare administration. So I worked with Sheila. I worked with Lonnie, not Peggy. Peggy Norbury is a physical therapist who works with the BNA, and she's here to talk about doing a home assessment. As you're getting older, what do you need to do to ensure that you're safe, to ensure that you have maximum mobility? Sheila will talk about home health care, home health nursing, what the BNA does. And Lonnie is a community care coordinator with the IPG Health Foundation, which is the primary care practice in primarily Woodstock. The center. So the clinical practice. There's also something in Woodstock called the IPG Health Foundation, which is more of a grant organization that you can talk to a little bit. But Lonnie's literally out in the field working with people trying to coordinate care to help them stay at home. Correct? All right. So quickly, is that all the homework, Dick? All right. So in terms of the outline that's kind of in your handout for looking at staying at home as you're aging, and this is kind of staying at home. As I'm reading some of this literature, it's amazing as us baby boomers are aging. Needless to say, there's so much stuff happening. If you go on the web, just I think in the last couple of weeks, what used to be called the National Care Manager Association or something like that is now called the Aging Life Care Organization. And instead of certified care managers, they're certifying aging life care professionals. So it's all these, to make everything a little more PC and all that kind of stuff. But it's just interesting. It's a very, very rapidly growing field because we know there's going to be a huge increase in the need. So in terms of just the part that Nancy was going to talk about, her piece really is the care management piece, the sort of overall care management for people. And what the professional care managers do, hers is a private practice. When she couldn't do it, she also referred me to Armistead, which has offices in Burlington and then somewhere in New Hampshire, but it's a small company. They were so great. She tried very hard to find somebody to fill in for Nancy, and they do the same thing. They provide caregivers, but they also have certified aging life care professionals who help families with the overall management of the care. And as these guys talk, you're going to kind of understand in some ways we all know how fragmented our healthcare system really is, and what the limitations are in terms of what's covered and what's not covered by entitlement programs like Medicare and Medicaid, or by private health insurance, or by long-term care insurance. We're just going to give you snippets. Anyway, so as in terms of care management, what Nancy is doing, what Armistead is doing, there's a group. Linda actually went to a caregiver session last week in Woodstock that was put on by the IPG Health Foundation. There's a group there called Connected to Home that are doing sort of the same kind of things, which is really helping families. So they'll come in, they'll do assessment and monitoring, planning and problem solving, education and advocacy, family caregiving, coaching. If, say, you're the family, somebody's living in a community here and your family is not here, they may step in and help to create a plan, help to manage, help to visit. I know Nancy has several clients at the Woodlands who live in a continuing care retirement community, but she is their family and their healthcare advocate when she's working for the family. Anne-Marie Plant, who's the president at Armistead, gave me this little story, and she said this would be a really good way to start without Nancy. So I'm just going to tell you the little story, and then we'll go ahead with the more detail. These guys represent a huge amount of experience in the field. So that's really the focus. It's the reality of what they live with day to day, trying to, helping people. So the story was, she said this actually happened today. She got a call from a gentleman in California whose mother was in the hospital here, lives in a assisted living facility in the Upper Valley, and he lives in California. She was in the hospital. He got a care saying that they were going to refer her for hospice care. She lives in the assisted living facility, but that she also was going to be needing 24/7 nursing care, I guess. Some kind of 24/7 care. And meanwhile, the son doesn't live here. The son's quote was, "I don't have a clue what to do." So she said, well, originally she's thinking, well, he's looking for caregivers. I mean, pretty short notice, and they do provide caregivers. And she says, really, I'm going to shift my thinking to thinking like an aging life care professional, which I am. And I think, what you're really going to need is caregivers for your mom, but also somebody who can help to manage that care for your family and help to put into place a plan for you and really be your contact person. And that's that just gives it sort of a nice kind of overview of what, easily could happen. And this profession that's really kind of up and coming in some ways, you guys do some of that, have all along, but really focused on helping families to manage the care. Although she said she's working with a couple in rural Vermont who have no children. And the mom has been the caregiver and is beginning to have a very difficult time holding everything together. So they're going to be going in and actually creating a plan for the couple and monitoring it and assessing and providing and doing all that stuff. So anyway, that's enough of me talking. So now we have 3, I don't know where we are with time. I told them they could have they only have 10 minutes, they can take 12. So we'll hear what Sheila has to say about home health care first.
Okay, so we are the Visiting Nurse in Hospice of Vermont, New Hampshire, abbreviated as VNH. The majority of our patients are actually served by Medicare, so I thought I would spend my 10 minutes talking about what the Medicare benefit covers under home health. Having said that, we do have private pay services and we can connect individuals with those private pay services, but the majority of the service we provide is under the Medicare benefit. And I think we all have a perception of what the Medicare benefit will cover, but it doesn't cover everything. It's an insurance policy which covers certain things, just like drug policies cover only certain things. First of all, to access the Medicare benefit under home health, you have to be under the care of a physician. So as all of you are sitting here healthy, I would encourage you to make sure that you have a relationship with a primary care physician so that when that time comes and you need services, that relationship has already been established. We can certainly help you access a physician if you come to us without that resource, but it's much better to have that relationship established ahead of time. You have to have a certain level of care for Medicare to pay for the home care services. You need to need intermittent nursing care. So the case that Pam was just talking about, if somebody needs 24-hour nursing care, the Medicare benefit will not pay for home health to be in the home. That's something that has to be arranged privately. You have to have a need for physical therapy, occupational therapy, or speech therapy if you don't have a need for nursing services. The agency that provides this benefit needs to be Medicare certified. This means that Medicare comes in and audits this agency on a regular basis, minimally annually, to make sure we're in compliance with all of the regulations that Medicare sets forth. And that's really a protection for anybody who comes to our agency for service. We are certified by Medicare. Medicare state surveyors come in on a regular basis. You have to be homebound, and this is probably the part of the home health benefit that is the most misunderstood. To be homebound means that it's difficult and taxing for you to leave your home. It doesn't mean that you're bedbound. So you can leave your home to go to doctor's appointments. You can leave your home infrequently. You can leave your home if it's difficult for you to leave your home. You can't be going out daily to bingo and on the golf course and have Medicare pay for their benefit. And again, that's to benefit all of us, because we want the healthcare dollars to be utilized for those that need them. And if someone can go out on the golf course, then probably they can get to their doctor's office to receive the care that they need. Under Homebound, you can go to religious services, you can go and get your hair done occasionally, you just can't be going out frequently. So things that aren't covered under home care, 24 hours a day care, like the scenario that Pam was talking about. Now, if this person needed personal care, somebody to help with the bathing, somebody to help with shampooing the hair, dressing, those kinds of things, we might have a nurse go in to help with a dressing change per se, or maybe some medication issues that might need to be resolved, but we wouldn't provide a nurse or a home health aide 24 hours a day. Having talked a little bit about the home health aide, I want to get into that regulation a little bit. Home health aides are individuals that go in, they're licensed nursing assistants, and they provide hands-on personal care for individuals in the home. Unfortunately, Medicare only pays for that if the person is receiving skilled service, the nursing service or the therapy service that we talked about. So if someone only needs personal care, Medicare's not going to pay for that to be provided. Now, sometimes long-term care insurance will pay for it. Sometimes Medicaid will pay for it. And sometimes people end up having to pay privately for that service. Medicare does not pay for homemaking service. And homemaking service is things that need to be done in the home to allow the person to stay in the home. So things like washing the dishes, doing the laundry, caring for floors, those kinds of activities Medicare will not pay for. But there are some long-term care insurances that will pay for it. There are some private insurances that will pay for that, because they realize it's important to have those activities accomplished for somebody, for them to stay in their home. Medicare doesn't pay for Meals on Wheels to be delivered to your home. That is something that I'm sure you'll hear about next month when the senior center is here, because in this area, the Bugby Senior Center is the facility that does the delivery of home meals. Medicare does not pay for that, though. As far as qualifications, somebody who's going to access that home care benefit needs to have either Part A or Part B of Medicare, and then it's billed under that insurance. Okay. That's what I have for home care. But I'm open for questions after the end. Yeah. Okay. You ready to talk? It's on.
Hi, my name's Peggy. I've been with B&H for about 6 years, been a physical therapist forever. But I'm going to talk about the fun stuff we do in home care, which is getting to go into your home and work with people. And this talk is about how to make your home, keep you safe in your home, which is pretty much what we do. And I think what I'm going to tell you is really what people worry about falling, people worry about balance, and what we try to do is minimize your risk in your home. People obviously fall, but we're trying to help you decrease the incidence of falls. So I'm going to kind of go through what we do. If you have any questions, just interrupt. But basically, starting from the beginning, walking into your house, you want to make sure if it's not a one-floor house and you have steps, you should have a railing. You should have good lighting. A lot of people don't, in Vermont, New Hampshire, a lot of people don't have railings. People enter their homes through their garage. They tend to be very steep stairways. If it's only 1 or 2 steps, you can just add a grab bar. It's a lot easier, but if it's 3 or 4 steps, it probably won't work because you have to reach for it. Then once you get into the house, if you have linoleum floors, if you don't have a non-skid under an area rug, that's going to create issues. Happens all the time. People, if they have hips or knees, or we go in and we have to have people take up their throw rugs because that's, you have a walker, get caught on it, you can just trip on it and it'll go slide. Good lighting's important. I think most of the falls that we see that are dangerous happen in the bathroom. So that's probably the biggest area. If you're looking at modifying your home to try to stay in your home, I think that's the area most people adapt the most. Walk-in showers are fabulous. Still, grab bars are great. Tubs are not great as you get older. They're harder to get into. We had a patient that was 94 years old, though, and she insisted on using that tub, so we helped her figure it out. But you can get tub benches or shower chairs or things like that. The toilets, these days now, they make toilets a little higher for people, but if they still sometimes are too low, so sometimes you can just add a little grab bar to the side of the wall, or put bars around the toilet to make it easier to get on and off. Beds sometimes are too high. I have a patient right now that couldn't get into her bed because it was too high, so sometimes we tell people to make steps, which is just buy one of those 4-inch steps that you use for step aerobics or something. Sometimes you need to raise your couch or your recliner. The chairs often sit low, so if you're a tall person and you're in a low chair, it's harder to get up. So sometimes people either put them on platforms, or you can go to Walmart, Kmart. They have these little 4-inch risers you can put under your chairs. They work. They help people stay safe in their home. I mean, believe it or not, if you can't get off your couch, it's a problem. But you put these little risers on, it makes a huge difference. I've had several people in their 90s stay independently in their home in a wheelchair. And you might think that's really impossible to do, but they did it. And that's kind of fun to be able to help an elderly person stay home, never leave her home, and be able to function. Trying to think what else. A falls risk assessment as we get older, if people feel like they're having balance issues, there's a lot of fall prevention in senior centers around. There's a really good balance program at Dartmouth Hitchcock for people that are not homebound. But people should get assessed for fall risks, because sometimes it's just adding an assistive device, a cane. Sometimes it's just getting stronger. Just simply being able to stand up from a chair without using your arms. A lot of people like to get those lift chairs, which I hate, because you get weaker. So as a physical therapist, we try to avoid people getting them as long as they possibly can, because people's quads get weaker and then all of a sudden they can't stand at all because they're dependent on the lift chair. That's pretty much what I do. I mean, I don't know if I ran through that too quickly, but occupational therapists come in and help too. So, do you have any questions? Oh, not right now. Well, the occupational therapist would really be the one to fully assess and adapt the bathroom, because they're experts in that area. But physical therapists in home care, we admit people to home care, and OTs don't, so we do a quick screening and decide and write orders for OTs, and they will go in and help people. But I'll tell you, Bugbee, for the people around here, Bugbee, before you go out and spend money, if you ever have somebody that needs an assistive device, they have a lot. The senior centers around here have a lot. We go there all the time and get it for people. Don't tell Sheila. But a lot of people can't get out, they don't have home, they don't have anybody that can do it for them, but they are a great resource around here. They're fantastic people.
feel like I'm at a karaoke place. I'm Lonnie LaRoe. Can you hear me?
Yes.
Okay. I'm Lonnie LaRoe. I'm one of the community care coordinators at the IPG Health Center in Woodstock. And as way of introduction, they had me go last because they know I can talk a lot. For those of you who live in Vermont, you're lucky, number one, because we have something here called the Blueprint for Health. And if you're not familiar with it, I suggest that you Google it and take a look. But the Blueprint for Health essentially is funding and a way of organizing healthcare in our state, and I don't mean Obamacare, so I'm not going to go there. This is where we are encouraging community health centers, such as the one I work for. White River Family Practice is another one. The Bethel Health Center is another one, to become medical homes. And medical homes means that you have a community health team that works within the medical home to support your health. The community health team that I belong to, we are the Windsor Community Health Team. We come out of Mount Scottney. So we are responsible, more or less, for the towns in Windsor County that would be most apt to be like going to Mount Scottney, but we're all broken up into areas. Interestingly enough, Hartford, except for Gucci, Hartford, that town belongs to Giffords, that center. So on the community health team, we have 2 or 3 of us that are nurses, that are care coordinators. We have a mental health person, we have a nutritionist, we have somebody who has a specialty in diabetes. We collaborate with what's called the hub and spoke, which is the way that substance abuse is now dealt with, particularly opiate addiction in the state of Vermont. The dietitians can bill, and we can bill for diabetes services by Nancy, and all the rest of us are free. So there's no better deal than free. So my role is that I work with the people in our practice. I also take referrals from the senior center. I take referrals from neighbors, get referrals from the, people on the street, the Woodstock Pharmacy. And they'll basically call us and say that we think somebody's having a problem, and we think that they need some help. So the areas that I am going to focus on is my topics. You can see my props here, okay? Is financial, social, and what are the resources? The financial part is my least favorite and probably the most necessary. So basically, it's expensive to take care of yourself as you get old, and that's just the bottom line. I see it every day with the people that I work with. I've seen it with my own parents. You have no idea if all of a sudden something happens and you have to hire the private care that was described before. The going rate for a private caregiver is somewhere between $20 and $30 an hour. So you multiply $20 times a 10-hour night, that's $200 times 70. You all look pretty smart, I think you can do the math. When my mother has advancing Parkinson's disease, and after she had and I feel so privileged to be part of her life because she manages that with such grace. But she was in a rehab center after some complications. It looked like my parents were going to need to move. My father had made that decision. My mother was not happy about it. She wanted to come home for a month to try to get things in line. They lived in a big Victorian house in northern Vermont, and they were going into a 1-bedroom apartment in an assisted living facility. It was $10,000 for her care, for her personal care at home. And that's with a very involved family. Because different from her other hospitalizations, we knew that we couldn't do the nights. We were doing the nights for a long time. And it was just hard. So that, I really encourage you to think about that. If you have long-term care insurance, I encourage you to read those policies very carefully. That's something I don't have a strong opinion one way or the other than the fact that you need to, if something happens and you can use it, great. I mean, so it's nice that you have it. But something might not ever happen and you might be paying a lot of premiums. That's the risk that we all pay in health insurance. But take a look at it, because long-term care insurance has a waiting period. It's, which is kind of like a deductible. So many policies, again, everyone is different. So, at least in my experience. So you might have to hire, and they work with certain agencies, it has to be an approved agency. So you might have to pay for 3 months, like your kind of deductible, for long-term care from the agency that you're going to use before your long-term care kicks in. Your policy might look like a lot of money, and again, I don't mean to be giving anybody a bad rap, I just think you need to look at it and don't think that it's a total safety net. You divide whatever it is they say they're gonna pay a month. I'm not gonna do the math really quickly, but it's like, say it's $2,000, $3,000, it sounds like a lot. Like 3,000 divided, say it's 3,000 divided by 30 days, that's $100 a day. Now you heard what I just said in terms of, okay? So, you're a smart crowd, you can do the math. So that's not gonna be enough. So, so you need to pay attention to that, and you need to think that that's not going to be the only thing. Now, if you take that same amount of money and you end up being in a residential facility, and you're putting that money towards private care costs, again, depending upon what your policy says, that can be very helpful. I mean, $3,000 a month, if they will accept the residence that you're in, towards a $5,000 bill is pretty significant. So, so I gave you, well, they're on the table over there. And I'm not going to get into this in detail, but I'd be happy to speak to anybody individually afterwards. This is something about hiring a private caregiver. A lot of people have never hired a private caregiver. You haven't really done human resource management. You need to check references. You need to check references beyond, Margaret that lived down the road knew this person who worked for somebody's mother and she did really good housecleaning. That's really different than somebody coming in and being there for a long period of time. You need to know what their skills are. This is an article on employing a private caregiver in your home. Tons of people employ people under the table. This tells you what the laws are. You want to be thinking about whether or not your homeowners or your liability insurance covers somebody if they have a fall. You want to think about whether or not you want to withhold, et cetera, et cetera. A lot of the agencies now are not really much higher at all than hiring a private person. It's a very personal decision, but it should be a decision that you're making as an informed person. So, again, not a popular article. I also brought something called the General Power of Attorney for Financial Affairs. This comes right off the Vermont Legal Aid website. It corresponds somewhat similarly to, I think people have talked about on the Vermont Ethics Network is where you can get durable power of attorneys for healthcare. This is a very simple form. It's legally binding. It needs to be notarized. I just did one with somebody this week. You can certainly go to a lawyer and have as many caveats put in it as you want. I would encourage you to look at this. You do not know when you might need this. I did not know that my mother was going to need this, nor till she needed it. My father died suddenly, and you needed something. And if somebody's a signer on your checkbook, again, all these little technicalities, someone's a signer on your checkbook, then they co-own that checkbook. But that does not, so if you die, they own what's there, it doesn't go into your estate. But that doesn't mean that they can go down to the bank and recycle your CDs or close a savings account or anything else. They can't find out what's going on with your insurance. So I would encourage you to look carefully at this and just consider it. You might never need it, but you should know who you would want to do that. Or you should know who you would want to help your spouse do it, should something happen to you. I see over and over again people who one person managed the books and the bills. The other person doesn't know. Another thing I brought today, but this isn't in the packet, and put more. I did an application with somebody yesterday for a long-term Medicaid program. I had never done one before. Hope I never have to do another one. But it was a real learning experience for me. Fortunately for me, my dad had anticipated that something could go wrong, and after he died suddenly, I found in his desk something that was dated 2 weeks before he died that said, upon my death, please look for, and I was his DPOA, and it said the name of the policies, exactly where they were, who was the contact person, and what was the phone number. Now, he had showed me, I don't know how many times he had said to me, and I wasn't really invested in, this is all in the black filing cabinet in the back of the closet. But I didn't really know what any of it meant, honestly. That's a lot of denial on my part. I suggest that you get out of denial if you want life to be easier for those, and even for yourself, because you could, you don't have to be dead to need this. And it's just things like your power of attorney. Where's your private health insurance cards? Where is that for your spouse? What are your health insurance premiums? Because if you have to apply for any other assistance, you're going to want to know where this stuff is. Where is the deed to your house? Where is the tax assessment for your house? Where do you keep the last annual statement for your life insurance, et cetera, et cetera. It's all, and you need it in a place where somebody else knows where it is, and hopefully more than one person. Because if you are somebody who has suffered a major loss or change in your family, your stress level is going to be like over the top. And potentially, maybe you'll be very calm. But if you're not, you want somebody to be able to help you. So, I'm probably almost out of time already. Well, I haven't even gotten where I'm going. So anyway, so I'm asking, oh, here. I have no idea. Okay, so I'm just asking you to think about that, to not be taken by surprise, to think about that, and to talk with your families about that. Somebody who is a significant, trusted other. The other thing is prescription drug costs. Sheila talked about Medicare. One of the things that I learned about in this job is Medicare Part D. My parents, again, I use them like they're icons, but that personal experience has taught me a lot. My father had a long-term care. He had a policy, supplemental policy, through his professional association. Well, even prior to his death, they had gotten something that said, January 1st, we're not going to do health insurance coverage anymore. And that had been their prescription drug coverage. So they had to go find Medicare Part D. Medicare Part D is what pays for your drugs. And there are about 30 different policies. The way to get the way to understand Medicare D is they send all these papers. If you're really good at reading and you like the internet, you can probably do this yourself. It's not too tough. You go on, you plug in all of your drugs, and they will tell you what is essentially what's the best bang for your buck. What you've got to look for is deductibles, premiums, and copays for the meds that are yours, and they're different for all the policies. The good news is that that opens for everybody October 15th to December 8th. All the senior centers have people that help people do this. Senior Solutions, Council on Aging have people who do this. I mean, it was almost criminal what my parents were paying for supplemental insurance in comparison to what my mother is paying for Medicare Part D, and she is on a ton of meds. So I encourage you to look at that. And it happens every year, and it can be different every year. Okay, so that's it for money. Now we're gonna go to the social stuff, a lot of which people aren't happy about either. That you need to really think that your life is gonna be different. I mean, as you age, your life is gonna be different. Your social supports are gonna be different. Your friends are gonna have changing conditions. You might not be able to play golf. You're gonna have to think about gym running. I mean, but you're not gonna wanna stay home and watch what isn't good on TV. So you really need to think about what your interests are and who can do that with you. It's very important that, the motto that if you don't use it, you lose it. I mean, you've got to be physically active, and you've got to do something with your mind and often with your hands. I saw her this morning, a 100-year-old woman who is sewing now and living in her own house. Now, granted, she's an exception, but that is one committed lady. And I mean, she pays attention to a lot of things, and she's doing it. So your friends will change. You'll find that you may be somebody else's caregiver. That's a big social change. And if you find that you are someone else's caregiver, to have a quality of life that's going to allow you to go the distance on that, you need to think about respite. And you need to think about how that's going to be paid for. And there are respite programs associated and funded by a number of diagnosis-related things. So I would encourage you to think about that. There is in your packet, I'm not going to go into it in detail, this thing about driving. Nobody wants to hear this. Everybody needs to be rigorously honest with themselves and with the people that they care about. You can look at this questionnaire, and you can see what makes sense to you. And if you choose to, you can look at the back where, when you're not having problems with your driving, but you know that there may be a point that that's going to change, you can read this and think about talking with your family about giving them permission to talk to you about it. Nobody wants to enter this conversation. Nobody does. With my mother, she went to a driver's rehabilitation program that I learned about at a conference. The reason we did that was so she could learn techniques while she could learn techniques before her illness progressed, so that it would be harder for her cognitively to learn. She's not at all demented, but her Parkinson's disease makes things slower, and that's what happens with a lot of other illness. So, and it helped. It bought her some time. Definitely bought her some time. And the adaptive equipment that the occupational therapist provided also bought her some time. And I appreciate the conversations about physical therapists. I would encourage everybody who's aging and have had a significant change in their health, watch Jill when I say this, to have a PTOT eval in their house. To have, it is Medicare covered. They go in, they do the eval, it's a lot of paperwork, God bless them, and they find out that you're not homebound. But you get the advantage of a skilled person looking around and finding out what is at risk in your house. And, people say, oh, I don't need home health. Everything's fine, I don't need home health. Well, let's try to keep it that way. So if you get people to come in, this is their job. You know, they are so skilled. I'm a nurse, I'm not skilled like an OTPT. And so I would encourage you to do that. These are my prompts, I'm running out of time. If you go out walking, or somebody that you care about goes out walking, and they're a little confused, and you know it, but nobody's talking about it, they should be wearing an ID bracelet. One day I was walking in Eastman in Grantham. This wonderful gentleman, very well put together, was walking. We said hi, and then he walked by us again, and it looked like he didn't know where he lived. Okay? Now Eastman's a little confusing, but he didn't know where he lived. And he was calling his wife on his cell phone. The phone was busy. She was talking to their daughter in California. Went on and on. We're going up and down the street. We finally called the Eastman office and gave them his name. They gave us his address. You know, a great guy, a wonderful guy. He would walk into the grocery store, you would have never dreamed that he couldn't find his house. But it's very serious. And if you have diabetes, if you're on Coumadin, if you're on something that you would want someone to know, and if you ended up in an emergency room, then you should have an ID bracelet on. I don't make any money, I don't care who you buy it from. I don't care if you get it from a jewelry store or you send it to one of these companies. Same thing with medication cards. I haunt people over that. They don't have to be fancy, they can be a index card. You do not want to show up in an emergency room that is a hospital that you know or you don't know and not know what your medications are. The name, the dose, and you want your partner to have the same thing. You want it in your wallet, that's where most people will look. And because it slows things down tremendously. If you're under a lot of stress, you just got in a car accident. You know, I was under a lot of stress. I couldn't remember my daughter's birthday. Much less would I have been able to list the 15 medications my mother's on. You know, it's something to think about. It protects you. You're being like proactive. Last thing, let's really be out now. Okay, it's community resources. Somebody's going to be talking to you about Lifeline. If you, even if you're not, frail, people think that Lifeline are for people that are frail. I'm trying to talk someone in Bridgewater to get in a Lifeline right now because nobody lives near her. Nobody lives near her. People don't stop in her house all the time. If she falls, it could be days. That's something to think about. The Meals on Wheels, it's not only is it convenient, but you have to think about nutrition. If you're not eating well, you're not going to be strong. If you're not going to be strong, you can break your hip. If you break your hip, your options are cut in half. Just that simple. And I ask people, so how do you want to spend your energy? Do you really want to spend all day making lunch? Or do you really want to spend your time like doing your laundry? No. You want to have the kind of quality life that you can, spending your energy chips the best way possible. So there are a lot of resources in this community. The Aging Resource Center, the visiting nurses, the senior centers. Call any of us that work for a medical home, we're free. Ask your friends. Have open conversations about who's going to do what. And what has anybody learned from anywhere that could help you. And I thank you for your time.
Yeah, thank you, everybody. That was actually great, Lonnie, because that's kind of what we're trying to do as the Community Affairs Committee, too, is to look at what kinds of things can we be doing in this community to help each other so that people aren't at home making lunch all day or, I love that. But kind of that's of great interest to us. So the next thing we have is, the only other thing I'm going to bump in quickly to the question and answer session, and then we'll formally start it. But there's this new program called SASH, that is a Medicare pilot program, correct?
You have to be a Medicare resident. I mean, you have to be on,
Here, take that, nobody can hear it.
sorry.
It's called Seniors at,
Actually,
like, at home safely or something?
Seniors at safe homes or something like that. Okay, it's also part of the blueprint. It's in Vermont. Once again, you can thank the people, even if you don't like their political spectrum, for us having these programs. Okay, there's a SASH coordinator. One was just hired in Hartford, Sarah Keir. And there is one also in Windsor that covers Windsor and Heartland. It started out as a program in Cathedral Square in Burlington. And the idea is to do case management services for people in their homes. They don't have to be homebound. They usually start out based in a project. Like in Windsor, there's 2 or 3 buildings that used to be like where the armory is. I'm forgetting their names right now. But then they also, they can have a panel of 100. So they also see people in the community that need case management services. They can be referred by anybody who can self-refer. The Hartford one is, I believe, based out of Greystone. Again, they're looking for a core population, but Sarah also sees people on the outside. Like I said, that's new, and they just started with a smaller number. That is also on the website, and I think, are they somebody coming from there?
No, we talked to them about having somebody come. The interesting thing about that program to me is that it's a Medicare pilot program, so they're using Medicare funds, putting them with the housing programs to start with, so more of the low-income housing programs. But the idea is to try to help people stay safely at home rather than having them be hospitalized. And so the long-term idea is to see whether or not it's worth expanding these programs where really through the Medicare benefit there would be some case management services available as opposed to the restricted services through home health. There's a little better service through hospice. The hospice benefit is a little bit more.
We talked about home health.
Yeah. Yeah, hospice, we're going to have a person from hospice VNA coming in August. So we will focus a little more on what the hospice program involves. And, you know, that's a whole different deal. It's a little more generous. But I just was kind of a little bit heartened when I heard about it, I hope. I tend to be optimistic. But that, you know, the Medicare program is beginning to look at the reality of our lives. And, you know, we don't want to be in a hospital. We want to be covered with some assistance to stay at home. Right now, we're seeing our communities, you know, the development of a pretty robust private care management sector, and then communities stepping up to begin to say, how do we really help our seniors stay in their homes? So Lyme has just hired a community nurse for the town. It's like going back to the good old days of the visiting nurse. And, you know, we're just kind of seeing this cycle going on. It's very interesting. But I thought the SASH program was really, you know, right now it's a limited resource, but it's a really cool program.
I think something else that you're going to see that's a relatively new program started in Burlington. There's one in Berlin, and we're working hard to try to get one in the Windsor Heartland area. It's called Home Share Vermont, where you might have a senior, or I don't know what the age cutoff is. I don't think that there's a cutoff, and they're essentially matching people with somebody who wants housing for reduced rent. They'd be willing to do certain things. A family or the person themselves wants somebody else sleeping in the house at night. It's very, people are very tightly screened. You can go on to Home Share Vermont website and you can find out, you can see all the tools that they use. You know, it's it's usually, I think I've heard that it's usually a match for a couple of years. It's often like graduate students or somebody, young professionals, and you barter. It's spelled out in a contract very specifically. But I think it's another really exciting option for people.
Yeah, it is. Using our resources that way. So we'll go ahead and start the formal Q&A. Does anybody have a card that you want to submit?
Thank you.
Yeah. And I was gonna give this to you.
First question,
So, yeah, does anybody have a
or a
question?
card that you want to pass out, pass in? Lonnie, you said Hartford was not covered, but Queechee is covered in the Ottaquechee,
Health Foundation.
in the, yeah. So this association is covered under her program.
Well, what the Ottaquechee Health Foundation, the Ottaquechee Health Foundation, which is separate than the Ottaquechee Health Center, and I think Sherry Thornburg came here before, did she?
Well, she did be the transfer.
Okay, so the Ottaquechee Health Foundation covers essentially 7 towns. That is their catchment area. Barnard, Pomfret, Woodstock, Bridgewater, Killington, Reading, Heartland, and Queechee. The village and Queechee. Why it's just Queechee rather than all of Hartford, I'm not really sure. And that entitles you to, again, I would strongly encourage you to look at their website, the Ottaquechee Health Foundation. They provide grants for people who need them for uncovered health-related needs. And I'd be glad to speak more specifically about that to anyone. It's for those of us, Sheila and I were commenting on that, for those of us who spent most of our lives in the nonprofit world, to actually have someone have a need that there is actually funding for is like, it's amazing. I mean, it's really a gift. It's a wonderful thing.
To Peggy, on balance and strength, the Queechee Club on the website has classes on balance. So rather than wait to go to your home, we sponsor here. Go to the website under calendar, and it has by day the different classes that are here. And you have to have 6 of us in a class, and most times there's 6 of us. And the details are on the website, so thanks for pointing that out.
It's worth it.
Can't answer. I don't think so. Call members only, I think, in that case.
Let's see if this is working.
Is this working?
This is work, okay. You mentioned the PTOT assessment. Is that, and that is done by the Visiting Nurse Association?
Well, we're one of you in the home?
Yeah, to have someone come into the home to do that assessment for
Yes.
what the risks
I
are.
mean, if you go to a rehab facility and you're going home, sometimes they do it before you go home. But yes, we come to your home to do it.
And is it something that you could assume would be done by other visiting nurse associations? In other words, in other states, do they have those same kinds of programs?
And we do it as a group, somebody just requests a private
You have to have an order
service.
from a physician.
Oh, from the physician,
So it's that relationship with the physician again, for the home health care.
You
right.
can't request it unless you're my friend.
You better be nice to her. And you're all her friends.
Thank you.
Lonnie, are you aware of anybody who does that prior to, like, the connected, like LOA?
I don't think that someplace like LOA or a private, I'm gonna put in a real plug for professionals. You know, if you're gonna do this, then you want it done by somebody who, that's their business, you know, an OTPT. I mean, you know, I can go in and sort of see if you got scatter rugs and electrical cords and a few other things, because I've been at this for a long time, but you want a PTOT. And you can request it yourself, and they will say to you, you need a doctor's order, and they can help you get one. When I say they, I mean the visiting nurses. I mean, they will facilitate that. If you don't have a doctor, it's a little bit tougher, but and I don't know, I defer to you, but I have never heard of a physician or that refused to give anybody an order for PT or OT.
No,
So.
it's just a phone call.
Yes, it's really just a phone call.
And if I can just jump in, I'm Jessica, I'm here from the Iowa Hospice, and there is another organization that provides home health services as well.
Could you put the microphone by your
If
mouth?
there's time, I would love to hear a little bit more about the hospice benefit from Sheila, but just so folks know, there are other services and agencies in the area.
Come back in August. She will keep doing that.
Okay, I know that in the future, there is going to be a presentation on hospice, so I don't want to spend too much time on that. But we do provide hospice services in the home as well as does BIATA.
Turn the mic on.
As does Lakeside PBNA down in the New London, Lebanon area. This is for people who have an illness where the expectation is that their life expectancy is less than 6 months. And so the comprehensive services that are provided include nursing care, physical therapy if necessary, medications related to that illness, the personal care assistance, the home health aides, medical social work services, chaplain services, and volunteer services.
Sorry about that.
And I really don't want to spend much more time on that because I know there's going to be a whole presentation on hospice care coming up, I believe, August?
August.
Okay.
And it is the.
Where's the other mic?
I got it. I'll bring it back.
We don't have roving mics
Yeah,
now.
that mic.
Because we still need the mic here. For some reason, this one does not.
So, I wanted to mention, and I'm not sure if you did.
It's on, put it close to your mouth.
But it goes to my, oh, now I can hear the feedback. That for Medicare, you should also think about having a proxy authorization before it's too late. So that if your spouse wants you to be able to call Medicare and do anything, you will need an authorization. And you have to do it for both regular Medicare and for Part D. Am I correct? Because that's what I just went through. So don't wait too long. You know, it can't hurt to just do it when you're thinking about it.
That's something else I might speak to. One of my favorite rules is HIPAA. And, but I think that you're all probably signed that questionnaire.
Well, you're not probably, yeah, they might not know what HIPAA is. but
HIPAA is
for-
when your health insurance, your health information is protected, and I'm all in favor of that.
Yeah.
You know, the problem is when a spouse calls and they want to know something and you can't tell them because there's not assigned permission. Or you have a daughter in Connecticut who's always been their healthcare advocate, but you can't talk to that person. Same thing with the prescription drug companies as well as with Medicare. In order, like for me to talk to different places, my family members have had to tell them that they want the release form, they send them the release form, they put your name on the record, and it has to do with every doctor's office, specialist. So you want that in place even if you never need it. And often what happens is that if somebody gets ill, the hospitals, et cetera, they want to talk to one person. And it's often the spouse or the person that's the closest. They don't want to have 15 conversations. So they want, one person that can disseminate the information without putting a lot of pressure on the people that are there. And if you get that set up early, then it's just one less thing that you have to do. Now, this is not all about doom and gloom. It's about being proactive, I think.
Absolutely, yeah. And I just want to say that it's not only for you all in this audience, it's for everybody. Recently, we had somebody whose daughter fell down the stairs and was unconscious. And she had her medication list at Dartmouth. She was at Fletcher Allen. It was 3 a.m. Nobody had a list of meds that she was on. And she was unconscious and couldn't provide the list. So encourage your family members also to be proactive and get these med lists available to significant others, et cetera.
Yeah, and the HIPAA thing is really just to kind of clarify, it's literally a release of information form. You're giving permission for somebody to basically talk with your healthcare providers about your care. And otherwise, all of your health information is protected, or what's defined in that law. Or the insurance companies, yeah. So it really is an important thing that we don't really think about. I'm sure you guys have probably had that experience of making a call and they say, sorry, we can't talk to you.
If you have a durable power of attorney for healthcare, do you still need to have these HIPAA release forms signed? You do. Ooh.
If you have a durable power of attorney for healthcare, if you have a durable power of attorney for healthcare, that works if you can't speak for yourself. That doesn't mean you can be somebody's DPOA and they durable power of attorney. But that doesn't mean that they'll speak to you about that. And it means that you are their proxy. Now some places might say, I had someone call me once for something to do with my mother, I'm her DPOA, and I said to them, why are you calling me for this? And they said, well, you're her DPOA. And I said, well, she's competent. She talks on the phone. So you have to be careful what the boundaries are. But there are some places that won't even let you schedule an appointment for someone if you're not on their list. It depends upon how literal people want to be. So I just encourage you to think about it.
Is there a HIPAA form that you mentioned? Is there a HIPAA form that you're talking about, and where do you get it?
You actually can get it on the web, but you have to kind of know what you're looking for. But I was I'm glad you mentioned that, because it was just occurring to me that perhaps our committee should get some of those forms and have them available to people. I'm sure Norwich has them. I don't know what, you guys have a senior center in Hanover. Senior centers probably have them, or your physicians easily can give you the form. Some of them have they've created their own forms. The release.
What I was just saying is that every time you go into a doctor, you've signed a HIPAA release. It's like one of the 6 things they make you sign when you come in for your first appointment. And then they say, is there any changes in your Medicare thing? Do you have renal disease? Have you ever, and oh, by the way, will you sign this paper? That's a HIPAA form that says that nobody reads it. It's about 1.5 pages long, and it says that all your health insurance health information is protected. They will not give it to anyone without your specific release. So that's the main HIPAA form, and you've probably signed it. Every physician, every specialist, every institution that you've gotten it. That's separate from when you ask them for a release of information form, which is also separate from when you sign a form allowing somebody to be equal to you in the say of your health care, and that is an individual representative.
It's a little confusing. It really is. It certainly talks to the value of that care manager.
I have it. Can you get that release for a facility? In other words, can I have a release for Dartmouth Hospital and all the nurses and doctors within that are associated with that hospital? I only have to do it once, or do I have to have one for every doctor that I see at Dartmouth? The hospital, I can have one for the hospital.
My understanding is you have one for the hospital. Essentially, they take care, within their own internal security systems, at least this was my experience there, they have different levels of password protection. So, and the law is actually based on need to know once you have the release. So at Dartmouth, not everybody, if they are your caregivers, they have a need to know. If somebody random who hasn't provided care to you tries to access your record, they're not supposed to be able to get at it, right?
Right, and if you're, in most facilities in this area, like if you come to our health center, or you go to Mount Scottney, and I suspect it's true of the other local hospitals, you're gonna be asked to sign a Dartmouth release.
Yeah.
It's an automatic condition, because I mean, you can refuse to sign it, but because that's where most of the specialists are in this area. Just like if you come to get a new primary care physician, and you came here from Connecticut, they're gonna wanna request records and access to whatever you had done in Connecticut. And they'll ask you to sign a release from your previous healthcare providers.
And with the electronic health records coming online, it's going to get a little more complicated, but in a way it'll get more simple because people really have to think through that whole algorithm of who needs to know.
And that's really for continuity of care. It's important that your healthcare providers be talking to one another. So because we have an electronic record, which is able to be shared among the physician's offices, the visiting nurses, several of the nursing homes in the area, it's important that those records be shared.
Yeah, and if you do look, when you go to see a doctor, you'll be, Lon's right, the likelihood is you're going to be asked to sign a release to Dartmouth. If you're here, living here.
And you're receiving care at Dartmouth.
Any other questions? Oh, wait a minute. This is the valuation form. So we really do want to know, what you thought of our program, and then also we're particularly interested in what other topics would be of interest to you. I sort of had a question about whether people, when we were putting this together, we were trying to figure out kind of, what would be interesting. Seemed the most interesting was making it be real life people talking who really work in the field, as opposed to somebody going over all the Medicare benefits, for example. But if people are interested in a program that is really focused on what does Medicare cover, what does Medicare not cover more broadly than just the home health benefit, and we will get into hospice, write that down. We can certainly arrange for Senior Solutions to come. They do a regular program about Medicare coverage. So thank you very much to everyone for coming.
We're going to try and get the handouts put on the website so you can easily get to them. Currently, if you go to the website as a member and sign in, on the right-hand column on the main page is our 5 programs. If you click on it, it'll get the detail of this week, of this month's program. It will then show next month's program in detail. Hopefully, we're going to be able to link to that on the handouts, and they will be there as a permanent record.
Yeah, we'll get them.
Stay tuned.
And on that, the Quechee Lakes, the Quechee Lakes website, which is quecheeclub.com, there is both a public and a private piece of that. There's a public website, and then there's one where the people who are members sign in. And what we're planning to do is get that on both. In other words, if you're not a member of Quechee Lakes, you'd be able to go in and also get the handouts through the public website. We'll get there. Thank you again, and if anybody's going up to have dinner, enjoy it, and otherwise enjoy your weekend.